Hi everyone, welcome to Help Nobody Told Us. I'm Shannon Johnson with Berkshire Hathaway, and today I am joined with my friend Jordan Kagan, part of our senior resource team.
And thank you for joining us today. Pete Miska is president of the Illinois Continuity of Care. He's also a board member for the Case Management Society of America and ACMA, which is the America Case Management Society, and very active as a board member with Illinois Hospice Association. And I've invited him because for now over 3 decades, his passion, his drive, and his care for working to service the most vulnerable population in Illinois, the seniors and the disabled, along with their families. I don't think there's anybody that is more knowledgeable and resourceful as Pete. His reputation is impeccable, and we're honored to be able to have him here today. So thank you for joining us, Pete.
Thank you. Thanks for having me.
Great. So, what inspired you to take on the role of president at Illinois Continuity of Care?
Well, I've been a member of Continuity of Care for over roughly 35 years. The organization's been around since the late 80s. Basically, its mission is to educate and advocate for the most vulnerable population. So basically, and it's mostly the post-acute care providers in the Chicago metropolitan area, plus we have a location in Northwest Indiana as well, too, that we do. And I was always an active member since the very beginning when we first started the organization. And we just wound up growing other chapters, and I was always in leadership roles in other different different chapters of the organization, but was never the president of the organization. And we wound up going through, which was very, very tragic for everybody, especially us folks in post-acute care, was the pandemic. So when the pandemic hit, because a lot of our members at COC, at Continuity of Care, are from skilled nursing facility, independent living facilities, assisted living facilities, hospice organizations, home care organizations, home medical equipment, home physicians, just everybody who's taking care of folks outside of the 4 walls of the hospital. But even some of the folks inside of the hospital are members as well, too. And then when we went through COVID, everyone got locked down. So there was a lot of folks that wound up leaving the industry, wound up having to basically, it was all hands on deck. So
They left or they got burned out.
Correct. It was one or the other. A lot of them took early retirement, and just realized that this wasn't necessarily something that they were expecting. So we wound up going virtual because we meet in person all the time. Right, so we wound up going on Zoom and trying to keep the organization together like that, but we're an in-person type of group. And so we started doing that. We had things in place in order to keep the organization going, but then we wound up becoming very anemic at the very end, because the pandemic went on for a while when they finally took off COVID restrictions. And then all of the rules and regs and stuff have changed, and a lot of things look very, very different on the compliance side of it that a lot of the folks had to follow now. And so there was a lot of change. So we lost a lot of members. So basically, I would like to say that people just tapped me on the shoulder and said, hey, it's your turn. We need you to do this. So it was my honor to step up and do that. So really what I did when I became president, which was about a little less than 12 months ago, was try to get the organization back in person, and then try to get each one of the chapters leadership back going again, get the educational meetings going again, get the membership back up going again, and find out who is who, because there was a lot of change. Okay. So a lot of transition, a lot of ownership changes, the health system's consolidated. Nothing looks the same that it did 48 months ago. And we had to kind of navigate through all that and find out who was who, and get them to have an interest with COC. So the fortunate thing about it with COC is it had such a good reputation and it was such a great legacy. We were able to come and do that pretty quickly, because everyone knew who this was. So when we picked up the phone and started calling folks saying we're trying to get the band back together, everyone was very receptive to pick up the phone and say yes.
Sure. So what is your background in healthcare that brought you to COC in the first place?
I am a respiratory therapist by background. As a very young man, when I first started in healthcare, I worked for Superior. Everyone kind of worked for Superior back then. Superior was a very big company. It still is a very big company. Still independently owned, and you see their ambulances all over the place, right? So they would start us in COC. So they would make us go to the meeting. There was only at that point 2 chapters. There was Chicago and Alpha, which I'm president of currently. And basically that's where we went. It was kind of like high school. They taught us, okay, we go to COC. They taught us this is the rules of the road. This is how we all interact with each other. Because COC consists of post-acute care providers, and everyone is kind of competitors of each other as well, too. So you have to figure out how to play well in the sandbox together as you're trying to take care of a population that's very vulnerable. At the same time, everybody is trying to grow their businesses and grow their census with their competitors. So you have to kind of figure out how to all play well. And so when I joined, it was great on the educational side of it because it exposed me to all these other people in post-acute, because I was just a little respiratory therapist that was just going here and just figuring how to
help people breathe.
Well, yeah, and so now this was teaching me how to have proper table manners, and how everybody else does their stuff, and it's just not all about me. Right? So it taught me that the biggest problem that everyone is having in healthcare is access. And that big problem at access is because people do not know where to go or what to do. And obviously it's happening at a time when they're at the most vulnerable part in a situation, right? It's mostly 911 type of stuff.
Right.
Nobody's anticipating it. Nobody wants it. Nobody wants to be a patient. Nobody has to be a patient. And so
help! Nobody told me.
Yes,
Yes, and we've talked before on our podcast here of so many of these things are happening to people younger and younger. 50-something-year-olds getting dementia, 40-something-year-olds getting dementia, and some of these unpleasant conversations that people don't wish to have need to be had. And I think, and I'm part of Illinois Continuity of Care. I'm a proud member. I'm not a president or a board member yet. I'm sure I'll be drafted in one day. But it's like, it's how can we help the most vulnerable?
Yeah, and create access for folks.
And awareness, and you talk about some of the growth that chapters have and the diversity of the members.
Yes, and that's just because, so basically continuity of care is most of the organizations in as we call the post-acute care space in healthcare in the Chicago metropolitan area in Northwest Indiana.
When you say post-acute, tell me what that means.
Non-hospital.
Okay.
Everybody else.
So anything outside of the hospital.
Yes, for folks who need care. So it could be somebody who, needs hospice care, or needs home care, or needs long-term care, or short-term care, or respite care, or moving services, or realtors, CSRC, or CRSA.
SRES.
SRES, there's an acronym for everything. But even
physical therapy.
Yes, occupational therapy, speech therapy, nursing services, you name it.
Retrofitting homes for accommodation.
Home medical equipment.
And I think that is where the hospitals, which are acute care, can become a member, want to be a member, because if I'm a social worker at a hospital or a case manager at the hospital,
they become a resource.
And I'm have to send someone home, Medicare doesn't want to pay if they come back in, or as an acute care facility, if I'm not setting people up for success when I discharge them, we get dinged.
Yeah, everyone is at risk for the payment now. So that's one of the missions of continuity of care at this point is so the whole healthcare system is in a process of going through a great big transition right now, and it's going value-based. So the current landscape is it's fee-for-service. So every time you do something, you get paid regardless of how many times you do it. It's going value-based. So basically that means that everyone's going at risk. So they're not going to be paying you 2 and 3 times to do the same thing over and over. They'll pay you one time, and if you don't do it right, they'll penalize you. So all of this is coming together because this is what's supposed to happen. So continuity of care is here to show everybody how to do that, how to create access for people and how to make sure that the care transition from one place to another goes safely.
Right.
Because that's where
And work
everyone
together
fails.
to make that happen. All these different avenues, and as they leave acute care, there's a whole lot of different people that need to enter
Yes.
that system at that point.
Yes, because usually when they're going into a hospital setting, they're staying for like 3 to 5 days, if they're lucky, and then they're discharging them. So they came into that hospital at a very vulnerable time of their life, and 3 to 5 days later, they're discharging them, stabilized, right? But
In quotation marks.
yes, they're stable because they can't do anything more for them in the hospital, but they can't stay. But that doesn't mean their post-acute services are set up, because now they're in a totally different situation. Let's say they had a fall. Everything was fine before, and now it's not, right? So how do we keep them safe? What do we do to do that based on the resources that they have, or what their social determinants of health are, their health literacy, access, all of that thing. So that's what we are. We're a group of all of those people, and then basically everybody is teaching everybody else what it is to gain access to their services and what the rules of that is. So people, they have a go-to in order to get care.
And you keep saying access, but I
It's
know
all about
firsthand
access.
how hard that is.
Yes.
My parents had a situation, and I moved them from Oklahoma to Chicago. And what I found out when I got them here is it's 6 months to see a doctor.
Depending on their payer source, yes.
And they both had, just to get them into North Shore or Northwestern or whatever, it's like they both had pressing issues that they couldn't wait 6 months to see a doctor. So it was like just racing to try and figure out how do we get them into a system and get them seen and get all the referrals that they need to start their health care in the state of Illinois.
And I think that you hit the word on the head when you said systems. The system. Because now it's not the individual doctor going into the hospital, rounding on their patients, and the doctor has a patient panel and that's how it's run. It's now the health system runs the show.
Right.
Because that's what going at risk means. The health system's going to be responsible for those people if they don't have a good outcome. So there's financial penalties to that, where before there wasn't.
Wow.
So now so now how do we navigate that? That's what value-based is, and that's what continuity of care is. So we educate our members on what value-based is and how to access it and all these rules that are happening, because quite frankly, on the Medicare side of it, you've got, as the system goes value-based, you've got most of the patients are going to be either in an MCO, a Medicare Advantage, an ACO, so accountable care organizations that's run through the health system, or some type of alternative payment model that Medicare is putting out. So when I say that, it could be like hospice is not an alternative payment model, but it's a different payment than Medicare usually pays. And they're in palliative and all these other things that they're coming out with to support the patients at home. And then you have so 50% of the folks are already on that in the Chicago metropolitan area. So they're either on an HMO or just on the Medicare Advantage alone, 50% of them are in Chicago, or Chicago Metro. And then the other 50% of the Medicare beneficiaries, probably half of those are in an ACO, so at risk with the health systems. So they still have their Medicare red, white, and blue card, but the hospital is responsible for the spend of that patient based on the physician that the patient chooses. And then you have another 25% of just fee-for-service Medicare patients. But the government's goal with the Affordable Care Act is basically to get everybody in value-based, just because there's going to be 90 million people over 65. So it's become an unsustainable model by just doing fee-for-service, and that's why they're going value-based. So the goal of continuity of care for the next 36 months is getting our members up to speed on what value-based is and whether they fit.
So we've talked about Illinois continuity of care. When we first did our introduction, we talked about Case Management Society of America. You just alluded to some of the ongoing education and awareness. So there is, for most of the members, CEU's continuing education units.
We've done what we've done, and what I've done with I've continued my work as the past president, is we've done collaborative with the other professional organizations, like you said, ACMA, CMSA.
Can you explain, so like, let's just say, like Shannon, she unexpectedly, a situation occurred in Oklahoma. You were forced with almost no advance warning to move your parents up here.
Right.
No planning, dumped on you, and might be a way of explaining it. You never probably heard of Illinois Continuity of Care back then, or Case Management Society of America. So for someone like Shannon that is brought to a situation with nothing in advance, is someone like Shannon able to reach out? What kind of resources can be provided, case management, referrals, things like that? How could one of our listeners
take advantage of any of these programs?
That's a great question. So currently what we've always done is I don't want to say that we've been talking to ourselves. We've expanded that, and now we're talking to the other healthcare entities, to let them know what we do. So we are currently the largest of the professional organizations out there, which is great. The bad part about it was a lot of people just didn't know who we were, right? Now they know who we are because we have the collaboratives going on. So if you go to our website, which is il-coc.org, you'll see all of the different professional organizations down there, and we're sharing with, through the best way to say this, through electronic formats, the websites and everything. And everything is interoperable now. So it's not just COC, it's everybody else. Where we're a little weak on is actually getting out and talking to the end users. We've always been more a professional organization talking to the other professional organizations. We've never really went out there and talked directly to the seniors, boots on the ground. Our website is set up, though, to help the seniors to do that, or any patient who needs the service. But in terms of having the folks that can help them, if they go to the website, they have a question, they can put it in the chat room, and then we answer them right away with whatever it is. So if there's a 911 situation going on and they don't know, and believe me, we can answer every complicated question that patient has.
Because it's been asked before.
Because we have over 40 years of experience, and we're the people who are providing the care. So if we don't know who does it, we'll find out who does, and we can refer them that way. Some situations are what they are, you know what I mean? Mm-hmm. But and those are choices. A lot of times we can't make people make good choices, but we can certainly lead them to some good alternatives.
Right. So can you tell us about a recent project or an initiative that really exemplifies the impact that ICOC has on making healthcare better within our community?
I can just give you a couple of just quick ones. Like, for instance, we had a meeting at, we have a South Suburban chapter that handles the south side of the south suburbs, and we had a meeting at Advocate Christ Medical Center. Mm-hmm. We had them hosted, and they have a food for pharmacy program, Advocate does. So basically, as the patients are being discharged, and if they have a food disparity or a food access to food, they can actually get them set up with a food bank and get them access, and the food is free. Right? There's a lot of that. So it's one of the social determinants of health, right? You're a diabetic patient, you can't get the right food that you need, you're coming back to the hospital all the time. And this will help do that. Our members didn't know about that. They want people to utilize that, and it's free. Well, it's free to the person who's needing the care, needing the services.
Right.
So we were able to connect the two together, right?
Yes.
And now all of a sudden everyone has access to that, and the program is going great. So that was just 1 hour and a half meeting. So we were able to bring 200 people together in an auditorium, in a hospital, and the 200 people that are attending that meeting are all taking group of a panel of people who need these services but just don't know how to get them, and that's what we're doing. We're connecting them.
Right.
That's just one meeting, but we have other initiatives that we're doing as well too, that are also changing with all the state and federal guidelines and the new programs that are coming in for patients to get access for things. So whatever that is. So we're constantly training them on the new stuff. So we're bringing IDPH in, saying this is how you do this.
Illinois Department of Public Health.
Illinois Department of Public Health. So that you're able to do this now, because just because your company doesn't do this, it doesn't mean that the service doesn't do this.
Right.
And then how do you do it correctly? So we are always educating our members all of the time. And our members they're out there just taking care of patients. They don't necessarily have these resources to be able to do this.
Sure.
You know, we're just hooking them up to do that.
So how do you align yourselves with the healthcare system to find out what the most important initiatives are? Like, how can you help?
Most of the time, we're getting that from our other referral partners. So, like we were saying, the case managers in the hospital, the insurance companies. We're talking
So they're
to the
saying,
payers as well.
they're saying to you, we have diabetics that are coming right back to us because they don't have food.
Yeah.
They can't get the right food.
Yes, or we have demented patients who can't be left alone, and they don't know how to act, they don't have any money. Or we have this, or we have that. We're able to then hook them up to all of the different resources that are available and who's providing that, because not everybody's providing. You might be the same business, but you might not be taking that type of patient, or not have access to those resources to be able to do that. So then what COC does, like I just already referred patients out this morning that I got called for. So, you know, because it's Friday, they need care. Nothing
Right.
stops,
Nope.
you know, and they
Still
can't
need
go
care on the
back.
weekend.
Correct. Well, and
And the holidays and all those times.
So they call us, and we're able to get that done, because everyone usually is in crisis when this is happening to them. And we're just trying to create access for people. And access is all about whatever their admission criteria or restrictions are. So we're kind of teaching everybody what that is. So you know, oh, okay, you need home care and your insurance is Humana? Well, okay, these are the 3 providers that can do that for you. If you're Medicare, here's 150. If you're United, here's 6 of them, you know?
Right.
How would they know that? They would have to call Humana. They
But
would
you
have-
already have that research done.
We already know everything done. So
Oh.
yes,
That's,
yeah. So everybody calls us.
that like solves a huge problem.
Yeah. So in order to talk to the hospitals and the payers, we had to not convince them, but let them know, yeah, you can try to figure it out, who owns who this day, or who goes where this day, or who bills this day, or you can call us. And we can tell you, like, within 2 seconds, which is what happened, which is what's happening now. And then the members themselves, as they're doing different initiatives, as they're talking, you know, if they can't handle a particular population of patients, then they're referring it to somebody else who can. Or when there's changes of condition, or if they have to add services, whatever that is, you know. If you have a bedbound patient and all of a sudden, you know, you can't do private duty, or they switch their insurances, or they get a stage 3 decubitus, what do you do? Well, there's different criteria in each one of those different categories so that people qualify for, or that they need for a protocol, and we're able to guide them to that. So it's like here, 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 here. And then we teach that in each one of the meetings.
That's a lot.
Yep.
Well, we have 11 chapters in the Chicago metropolitan area and Northwest Indiana.
How many members does Illinois Continuity of Care? Illinois Continuity of Care has approximately how many members?
Approximately currently about 800 members.
Okay.
Okay, and we're in the new, so we're the largest of all the groups.
And pre-COVID, what was your membership? 'Cause I know
It
you
was
said-
actually lower.
I know.
So we came out of COVID with a bang, where a lot of these other organizations are still hobbling. But we were really...
Congratulations.
Oh, thank you. And a lot of the stuff that we did was all with suggestions from the members. So we took those. That's why when every meeting, I'm like, our motto is, if you're not happy, we're not happy, right? At COC. So we'll say that to the members and ask, what can we do to help it be better? And we're able to do that in real time. So we take those suggestions and we're able to get it. Most of it is always about access.
Well, speaking of that, are there any upcoming programs or strategic goals that you're excited about that you can talk about, maybe?
Sure.
Long-term vision, the next few years.
Well, we're gonna be expanding. So after COVID, we added a couple of chapters. So we brought on Northwest Indiana. So we brought on the state. That's doing great. We also did a collaborative with some of the other professional organizations out there. So that thing is already cooking with gas. I mean, in a really good way. And then we've got another chapter that's starting off. Heritage Corridor, which is
Valley.
Fox Valley. So we opened up a lot of chapters after COVID, because the problem was that people were they didn't know where to go, and then we wanted to make it as convenient as possible for them. And then obviously we'll look at Wisconsin next, because it's a border of Illinois.
Right.
So there are people going across the border all the time, and those people are having a real hard problem, because Indiana is different than Illinois. So you could be working in Illinois and living in Indiana, and it's two totally different rules of the road that you have to follow.
Oh, yeah.
So that, and then also more education to help our members so they can do better care and improve their revenue and get access to more patients by keeping them contemporary in whatever their services that they're providing and who's paying for it at the time. So they've got like the guide model that's coming out. It's a new initiative to take care of Alzheimer's patients in the home. There's a lot of things in home care that IDPH is putting out, so home cares can do more above their, giving them more ability to do things at their at the highest level of their licensure, so patients can then get more access. A lot of times the organizations are a little apprehensive to jump into something like that right away because, they're afraid that they might get in trouble, or IDPH this is not what they do, or they weren't doing that 10 years ago. So we're trying to keep them all contemporary in terms of what the state and federal guidelines and what the payers are telling us they want us to do.
Sure.
And people will have to figure out, and we're going to help teach them how to do it better, faster, and cheaper to create more access, because costs are up, reimbursements are down. That's just kind of what's going on in healthcare right now.
And everywhere else, right?
Well, and everywhere else, yes.
What? Thank you. It's been great.
Yeah, it really has. So what do you see as the biggest challenges moving forward in this sort of care, and what's the next steps?
The fortunate thing about it is that we did a really, really good job talking to the other organizations, and they've invited us to really help support them. That we're just right now it's handling the growth, and I mean that in a positive way. So we're constantly changing, like every day, to be able to make that happen. So we're like opening up new chapters. We're constantly being more involved and being pulled in with the referral sources like the hospitals and the payers. And actually, the next thing would be like to talk to payers about what we're doing and who we are. I don't want to say create an Angie's List, but basically a go-to area for post-acute care providers. Because right now what happens is everybody has ways of contacting it, whether it's through electronically or the telephone or fax or whatever, but they really kind of don't have a go-to list, of who are the people that can do anything for you, right? And in Illinois, that's us.
Well, and I think sometimes you don't even know what services are available to you.
Yeah.
That your insurance will cover.
Yep.
Oh, like, who knew that was covered?
And we can tell them that. We already kind of know. Based on what the product is and what the plan is. We have nurse navigators in our group. We have patient advocates in our group. I mean, even if you need to hire someone to do, like in your situation, we have patient advocates and nurse navigators. You could have hired one of them and they could have arranged all that for you here. I mean.
Hindsight.
Yeah.
I mean,
yeah.
My father was, may he rest in peace, was in a facility, a senior community for rehab. And I don't think we had 24 hours notice for when he came home and had to make that house handicapped accessible. And we had literally less than 24 hours notice.
Well, and they're not letting him stay that long either. So it's not like he was there for 24 days probably either, right? I mean, it's so not, they're moving the patients sicker and quicker, in the care continuum, because once you've kind of hit the plateau of where you're at, it's not, well, no one's going to be able to pick me up till Monday, or we can't do that test till Sunday. It's no, we're doing the test at 7 o'clock tonight. You're leaving tomorrow at 7 a.m. It's like that. I understand it's Friday, but we discharge more patients on Friday than we do any other day. Just because Saturdays and Sundays a weekend, we're still open, but you just can't sit here.
We just don't have as much staff here, so we would also maybe like you.
They're not getting paid. It's that simple. If you're sitting in a bed and it's not medically necessary, or they said they're only paying for 3 and you're keeping them for 5, guess what? They're only getting paid for 3. So everyone's eating all that extra cost. They want you to move the patients. So in other words, it's 24/7 now. So it's not you get a week to do this and 2 weeks to do that. It's, they're admitted today. They're going to be leaving on Wednesday. We need to have them someplace on Thursday, So unless you don't want to hold back or an unfortunate situation to happen so they don't leave then So everyone's planning to do that, but
This is such a needed service, and I think people don't know about it. And so it's so important that the word gets out there that this is available, that one phone call can open up this avenue. Because I know that when you're in that crisis mode, your wheels are spinning.
100%.
Yeah.
And you don't even know where to turn next.
Yeah.
Because I've lived it.
Yep. So if, let's say, you're like a vet and you have insurance and this and that, you don't even know what's available to you because, all of a sudden you get struck by a bolt of lightning, like type of situation. It just happens and then everything changes, and you need to know what you can get or what's available to the patient to be able to, have some
and
type
as
of,
you're trying to help your loved one, you still have your life going on around you.
100%.
I had children and a job and all of this, and I'm spinning out trying to figure out how I take care of mom and dad.
Yeah.
So it's a difficult situation, and I'm not the only one. I am not like pretending that I'm the first one that's happened to. This is a very typical situation.
It's going to happen to all of us.
And it happens every day.
Yeah.
So
it's not even because people say, oh, didn't you prepare for it? And nobody's planning on being a patient.
You can't prepare for the unknown.
Yeah, so much of this, there's some folks that are just doing things that they shouldn't be doing, and that's a choice, you know what I mean? But, things just happen.
And it's like I have said before, have the uncomfortable conversations with your loved ones about what do you want to do if? How do you want me to handle this? Have the uncomfortable conversations ahead of time when everybody's healthy, when everybody's minds are 100% or close to it.
We all know that we're all getting one day older and one day less functional, right? It's just kind of how it works.
Right. Yes.
So nobody's going to ever change that.
Right.
So, yeah, planning is always the best thing.
Absolutely. And knowing that this is out there, have things like Illinois Continuity of Care in your back pocket so you can make that phone call and find out what resources are available to you.
And even the competitors say that. So that it's a pretty valuable service when the competitors think it's probably one of the highest valued things that they do.
Yes.
Talking to their competitors.
Yes.
We can learn from our competitors, and as I've said countless times, when you're dealing with the most vulnerable population, the seniors and the disabled or the neurodivergent population, our goal is to help them and their families. And to me, when you are in it for the right reasons to help individuals, we're on the same team. It takes a community. We're not competitors.
There's very few people that I've met let's just say COC, I'll use an example, that are not sincere about what they're doing. They're all trying to do the right thing.
I've not met one in the 3 or 4 years that I've been.
They're people, so some you like better than others, right? But in terms of what they're doing,
right.
You know what I mean? Their mission and what they're trying to accomplish. Some know more than others. Some are better than others. We're trying to just continuity of care is here to just make sure that population, that we're just promoting patient-centered care. Beautiful. That it's just all about the patient. And then the rest of us are just a tool in the toolbox to pull out to take care of that patient when they need it.
To make the rest of their life better, more productive, happier, all of that.
Everything.
All of that. Make it a better, more productive life as they live it out.
And the families.
Yes.
And their loved ones.
Take care of them and their caretakers.
Yes. Sometimes the daughter is running the show, and a lot of times she's the one who needs the most attention because there's
she needs a break. She needs a little rest.
Well, she's calling the shots, and she's tired and whatever, right? So
the daughter might be a mom. The daughter might not know where to turn.
Yes, so you're the daughter. So you're dealing with the daughter. Right, in terms of all of this stuff.
Sometimes you have kids 20 years younger than you, 25 years younger, and sometimes you have a child that is like 25 years older because now your parent has become like a child.
Yeah.
That you have to take care of them.
And a lot of times also is you've got the husband taking care of the wife or the wife taking care of the husband. Yes. And both of them are infirmed.
and it being pulled in so many directions.
But we just got to remember that number is going to be really big. 90 million people is a lot of people.
10,000
10,000 a day.
And actually here in 2024, it's going to be 11,000 baby boomers turn 65 every single day.
Yep.
And that it will become that 90 million.
Yeah.
That you're talking
That's a huge
about.
number.
Yeah, and then you've got the certain percentage of there that are going to, percentage that are going to be consuming 90% of the resources, depending on how well they do that. Very small percentage, and so it's you can't treat them all the same. You have to treat them all
No,
individually.
as individuals, right?
Absolutely, because that's the only way it's going to work. So that's a tall order. And that's basically what the people in continuity of care do, the folks in that group.
Absolutely.
Thank you.
Well, Pete, thank you so much for being with us today. We
Pete.
appreciate your insight.
Thank you for your friendship, your professionalism. You're always a good person that I know that I can turn to. And I hope the listeners here today really have learned about your organization and the services it can provide. And if someone is about to scream, "Help! No one told me," or "No one told us," now they know that you are there.
They can go to
help.
They can go to il-coc.org.
And it will be on our site as
Absolutely.
a resource afterwards.
And thank you for tuning in with us on Help Nobody Told Me. Come back next Wednesday for another episode.
Thank you.
Have a good day.